That was a little dirty. Yeah, sorry.
Wow.
It's very
grimy.
We can man handling, woman handling them. I guess so. Person handling them.
It's really dirty
All right, I'll read the history while you figure that out. Patient is a 15-month-old who presents with leg pain and swelling of 1 week duration, thought to be secondary to some vaccine shots they received. Parents do not recall any specific event/fall.
So are these BST Frozens?
Yes.
Okay, so I thought these were head and neck frozen things.
Oh, no,
You just, like,
I'm
like
sorry.
swelling.
No, because we replaced one of the head and neck sessions with Peter, so. We're gonna go back to, we're just gonna finish whatever BST ones we have.
All right, so sorry. I'm just seeing this separation of cells that are a little angulated, interspersed with some skeletal muscle right there. It like blurs when I look at it in here, so I'm just gonna look at it in here if that's okay for a second. Just so I can. Stroma is like a little loose. A little pleomorphic, but like I'm figures while I'm looking, skeletal muscle interspersed in there.
We'll get head and neck frozen at some point. Yeah, keep going. Yeah, what does that region look
It
like?
looks like osteoid or chondroid each.
Yeah, okay, kind of chondroid.
So it's kind of concerning.
All right, pause there. What about that?
Yeah, there's some plump like epithelioid looking cells. Sure.
What are they next to?
Yeah, they're next to let's see, collagen maybe, dense. Can't tell if that's like osteoid again. Maybe
Osteoblasty.
okay, yeah. Inflammation. I go back to those cells in a second. Just looking around. Look, like these like cells like interspersed like within this, like it might be bone, like calcification, bone, dense collagen. I think at this point you get worried about like a chondrosarc. So what were the imaging and like the
Sure. So the X-ray findings are left femur, an oblique fracture of the proximal to mid femoral diaphysis is present. The distal fracture fragment is displaced medially. Callus surrounds the fracture. There is marked soft tissue swelling with fat stranding in the subcutaneous tissues anteriorly and laterally.
worry about like an osteosarc or chondrosarc, just like based upon that.
It's no patient with a history of trauma or osteoporosis.
It's a 15-month-old, and according to the parents, there is no history of falling. However, based on the imaging, they basically see displaced fracture with callus and soft tissue fat stranding. apparently they don't see, like, they don't necessarily see an underlying lesion
Oh,
right, um, confirm that it's pathologic.
Not that I see so many inflammatory cells.
Mm-hmm.
Now we have these like kind of ribbing
Mm-hmm.
and like soy bluish material.
Mm-hmm.
I'm having a hard time calling this.
Mm-hmm.
And I don't know if the patient doesn't report trauma, then the patient was under child abuse or something.
oh no.
So
like-
I'm actually hesitant calling this.
It's not nodular fasciitis, it's not like sinus ossificans, like. It's not,
bony.
yeah. I guess you could call it, oh, sorry, like fibrous dysphagia, I mean, I don't think so, but I'm.
So, so for the purposes of the frozen, right, we have to determine
Yeah.
whether this is neoplastic, not neoplastic, potentially benign or potentially malignant, right? And so the findings that Mike is picking up
Yeah.
of, I think those, if you go back to the epithelioid cells that you were looking at, yes, those are osteoblasts. They have
Okay.
kind of paranuclear Golgi clearing POFs, and they're rimming along this pink material. Can you focus up on the screen maybe?
I'm sorry.
And the pink material in this case is osteoid. Number one, because it's rimmed by osteoblasts, and number two, there are some osteoblasts like even in it that are being entrapped.
Okay.
And so when you see this, you know, up here even, when you see this pink material with osteoblast rimming, you can pretty much kind of assume that it's osteoid, and the osteoblast rimming also kind of implies benignity, right? It implies either some kind of reactive process or some kind of benign neoplasm, because osteosarc is disorganized, it wouldn't have osteoblast rimming, okay? So that implies a reactive process. Then you have these other areas that you were saying of kind of fibrous and vascular stroma. So maybe, do you want me to take over?
Sure.
Okay, sorry. I think this is really important, and I think it requires a little bit of a discussion in terms of how we conceptualize these. Sorry, yeah, this is the morning problem with the scopes, like hot scope, cold hands, hot scope, like it sticks and it condenses and it gets all nasty. Okay, so areas of this kind of fibroblastic vascular stroma, and I think we can all probably appreciate that it's not extremely atypical, right? These are pretty bland ovoid oblong nuclei. We already talked about why the bone is not necessarily concerning because of the osteoblast rimming and the relative blandness. And the last kind of feature that we saw but glossed over, skeletal muscle, right? So there's some associated scarring, fibrosis, inflammation, whatever, in the adjacent skeletal muscle area. And I think this is a nice example of a range of, you know, it's a kid, right? So it's not big muscle, it's small muscle. You can see how the skeletal muscle looks here when it's gotten kind of atrophic and fibrotic, okay? And then lastly, where's that cartilage? Let me focus in here, right, too. You saw it at one point. Here it is, okay. So you also now have these chondroid islands that, again, you have to evaluate the cytology of. Are they enlarged and atypical with prominent nucleoli and mitoses, or are they, I mean, they're a little plump, but not necessarily hyperchromatic nuclei or angulated or anything. So, you know, altogether, do you perceive this to be, you perceive this to potentially be malignant, I guess is the question. Yes or no?
No.
If no, then what is it? Is it even neoplastic? And so I think this is a really good example of something that is not neoplastic, that you always have to be on the differential for, even if they tell you, no, there's no trauma, because people lie, right? And especially if they're trying to protect something that they think is not savory. So what, regardless of what you would call this on Frozen, what do you think it represents? At least we can call it not malignant, and that's the most important thing.
Reparative process, like injury followed by.
Some kind of reparative process, injury, so specifically, put a name to it. 2 words. What?
Like non-accidental trauma or reactive process, or are we thinking like that?
Like a
or-
histologic diagnosis. Even a clinical diagnosis, but really a histologic diagnosis. They said it in the X-ray diagnosis. Callus, fracture callus, okay, so you don't have to call it a fracture callus on Frozen, but that's what this is, okay? So fracture callus is a combination of, you have to permanent, of
So the same.
cryo, level
And
3.
then it's a beat and a heartbeat.
See what they look like. So fracture callus is a combination of what? Of reactive fibroblastic and vascular proliferation, of woven bone, osteoblast rimming, of immature looking cartilage, of inflammation. All right, so it's all of that kind of triumvirate, haphazardly arranged together. And I think you're never gonna, that's where I'm looking for, come to that if you don't have that in the back of your mind kind of at all times. And so here's a nice example, right, of this area of some bone and some cartilage juxtaposed next to each other. But again, the chondrocytes look nice and evenly spaced. They look to have pretty small, non-atypical nuclei. The bone, again, is looking quite bland with small osteocytes in it. This is a little more mature than the woven bone we saw earlier because it doesn't have quite as much active osteoblast rimming, but it's still, you know, in a later stage of wovenness, okay? So yeah, this actually, I think this happens on occasion where you kind of can almost suspect child abuse when you see fracture callus in a kid that has no underlying pathology and the parents deny trauma, right? So Mike is right. And don't be fooled by clinical history because sometimes it's inaccurate. So what do you guys want to talk about with this case? Yeah.
So if we see the exactly same pathologic finding, history is different.
Mhm.
Say they suspect a lesion
Mm-hmm.
and they get this,
Mhm.
will we then think that this is actually lesional versus is it something surrounding they're not picking up the real lesion?
So do you, I mean, if you don't see lesion, you don't
Yeah.
see lesion, right? So it could be something surrounding the lesion, so maybe they've missed. Because sometimes you can have, you can have fracture callus surrounding a pathologic fracture and have missed the pathology, but just get the fracture, right? So yes, so absolutely.
Then do you tell the surgeon to give you more tissue?
Yeah, I mean, in that case, you have to work with them and say, I only see fracture. If you're suspecting a lesion, like I need more, you didn't get it. In this case, if they're like, yeah, we don't see a lesion, this is probably it, like you may be done.
Okay, so you just have to.
You have to, and you know, in this institution, they're always very, very amenable, right, to that kind of discussion. So just get used to having that kind of discussion because it's bone and soft tissue pathology are incredibly integral. Oh, there's nice bone between, you know, pathology, the radiology, the clinical, right? So to make a diagnosis in isolation is always frowned upon. So yes, always have that discussion.
I have a question too.
That all makes sense.
Can you hear me?
If
Hello?
we saw like some bony stools, osteoblast.
Mm-hmm.
I know we talked about this before.
Oh, yeah. Like if you saw this, like bony spicules with background fibrous.
Yeah, and a child with a fracture, I guess
Yeah, you could think about fibrous dysplasia, but you'd want the radiographic images to support that, right? You'd want some underlying, ground glass kind of appearance and bowing of the bone. And I mean, you wouldn't want to necessarily make a diagnosis of fibrous dysplasia if there's no radiographic evidence for it. Yeah, so just to recap on that past one was called bone, osteoid, and skeletal muscle with reactive changes. And then the final was consistent with fractured callus. This is a 48-year-old male with no past medical history who presents with right knee pain. Who presents with right knee for 1 month. Right knee pain for 1 month. He felt like he hurt it weightlifting, but didn't seek care until a couple weeks ago. X-ray of knee shows a radiolucent lesion in his proximal tibia. I should see if there's anything in the chat. Yeah, if any of you guys are trying to speak, you could try to speak. If we only get woven bone and rimming osteoblast, I can consider osteoblastoma. Yeah, exactly. So I'm just gonna go back to that comment. So woven bone with osteoblast rimming, you can think about osteoid osteoma or osteoblastoma. But again, you need similar to fibrous dysplasia, you want to have radiographic, evidence.
Willpower is guiding through. It's pretty homogeneous in a way that we have sheets of cells, lots of giant cells that can be easily spotted. Willpower, background, relatively benign things with the cells where come on. Areas of necrosis. Wasn't the knee you said, right?
Yeah, around the knee in the proximal tibia. So MRI shows a multilobulated 6.5 centimeter mass that extends from the articular surface to the tibial metaphysis. The mass is of similar signal intensity to skeletal muscle on T1 weighted imaging, hyper intense but no fluid signal on T2.
6.5, that's pretty big on the it's like it's the history and what I see, I guess it's giant. Because there are other tumors that can also have giant cells, but I think the number we have here is quite a lot. That's really the only thing I see.
There was a radiolucent lesion in the proximal tibia on X-ray, which is multilobulated and 6.5 centimeters on MRI.
So like an air fluid level or?
No fluid. What would be your differential then?
An ABC.
See, yeah.
Giant cell tumor.
Right, right. Yeah, so giant cell rich lesions of bone include giant cell tumor of bone, aneurysmal bone cyst. In kids, you would also want to think about what?
Even osteosarcoma can be giant cell rich.
Well, usually not in kids.
Granuloma.
Oh, cherubism, giant cell reparative granuloma in the jaws. Okay. I'm thinking. Myxoid fibroma can have giant cells. So how are you, you said you're favoring your GCT bone. Tell us.
One thing why I favor that is that some of these giant cells are really, really giant. It's
Yes.
not like 5.
Yes.
Yeah, it's like here in this
Yes.
field, they have like
20, 30, yep.
whatever. And
Yep.
I think I read somewhere
No,
that
no,
that's rare in other tumors that
Yes.
could have giant cells.
True.
The fact that it's kind of like uniform, we have
Yes.
other areas that may tip us towards other differentials.
Mhm.
That's another thing. And I don't know what that was, but I see quite a few inflammatory cells, not necessarily in this field, but does that
Yeah.
really tip you towards anything?
No,
Differential?
no.
But it can be. And the fact that it's pretty big, the site also matches, so I'm
Yes.
favoring that. So I guess I could say. No, cell lesion reviews, giant cells favor GCT, something like that. I don't
Yes,
know.
yes. So one, again, with bone, always importantly, benign versus malignant. 2, in this case, you actually can make the diagnosis, like it's very characteristic. So if you go back to the areas with, multiple giant cells, the giant cells are relatively evenly spaced, which is characteristic. They have many nuclei characteristic. And if you go in between the giant cells, you'll see that there are these blandish mononuclear cells in which you flip the condenser, in which the nuclei are still relatively bland, and they say, maybe it's better on permanent, but they say that the nuclei of the mononuclear cells are somewhat similar. How about this one? Frozen, are somewhat similar to the nuclei of the giant cells. So, what are the neoplastic? This is non-frozen tissue. What are the neoplastic cells here?
Stromal cells.
Clear cells, and the giant cells are the bystanders. So go in one of these areas on higher power and investigate the mononuclear cells. In this case, the giant cells are numerous. But you can see how the nuclei are kind of open, maybe only slightly wrinkled, maybe tiny, tiny nucleoli, right? Pretty bland looking. Condenser, please. Is that bad? Yeah, maybe it's the other way. Yep.
The other one?
No, the other way. Yeah, yeah, the way you had it initially. Right, so not really hyperchromatic, not really mitotically active. The thing with giant cell tumor, these guys. The thing with giant cell tumor is they can't have some mitoses, but not atypical. They can be big. They can have cortical destruction. They can have vascular invasion, right? They can have all these nasty things and still be essentially benign giant cell tumors that can locally recur and can locally destroy. So what do you guys, how do they sometimes treat these things? Do you remember? What? No.
Just curettage.
They can curettage if they're small-ish or medium size. If they are large and destructive, they can sometimes give drugs. So do you know what these?
Yeah.
Yes. Anti-rank ligand, denosumab. Yes. So this is treatment naive. This is not denosumab treated. But I don't have an example. I have one back somewhere else. Do you know what happens with denosumab? Mm-hmm. Yes. Yes, the giant cells go away. you get increasing amounts of fibrosis and then osteoid bone deposition. So you get a complete morphologic transition in the way these things look after denosumab treatment. So at some point, remind me, I can show you a post-denosumab case, but they can look like fibrous dysplasia, they can look like low-grade fibroblastic osteosarc, they can look like just fibrosis, and because they lose the giant cells. So you really need in order to make the diagnosis, you need a diagnostic, either pre-treatment biopsy, or what's the mutation that these things have that we can stain for? Histone. So there's a couple different histone mutations that exist out there in the world. One is specific to giant cell tumor of bone, and one is specific to glioblastoma. And it's I can't remember, it's the G34W versus the K, blah, blah, blah. I have to look it up every time because I don't remember, but when
G34W for.
G34W for GCT bone. So this is a Mayo immunostain for the histone G34W variant, right? So you can see how the giant cells are negative and the background mononuclear cells are positive. So if you ever are confused between giant cell tumor, aneurysmal bone cyst with, or GCT with secondary aneurysmal bone cyst, or treatment effect or whatever, this stain is like super, super, super helpful and very specific. Yes. So we send this out to Mayo. I don't know, for those of you who've done Mayo send outs with me, but they do kind of like I can't remember, I think we had something else previously in one of the cases. They do the immunostain and they don't interpret it, they just send it back to you for interpretation, so it's like tech only. But it's a really good option. Yeah,
Wait, back on the.
back on the H&E. Can you find the mutation for the chondroblastoma?
Yeah,
Thank you.
we look, apart from those epithelioid
Mhm.
nuclear cells, which are described as tumor cells, also more spindly cells, right?
Uh-huh.
Are they just like capillaries? or
Yeah,
is
so
it-
some of these, I think like this is a
Yeah,
capillary, you can see
okay.
blood in it.
Uh-huh.
The background cells of giant cell tumor are mostly plump, can sometimes be spindled, but if you start seeing a lot of spindled, then you may want to shift your thinking to a solid type of ABC because those tend to have more spindly
Oh, I
cells.
see.
Mhm.
'Cause I saw.
And I think
So
these are
those are
vessel,
just
yeah,
vessels,
I think
okay.
those. K36M for chondroblastoma, thank you. Yes, giant cell tumor on frozen, good for them. And call giant cell tumor on permanent, immunostain for histone is positive. Brave. Thank you. Patient, a 13-year-old male with a lytic lesion in the right proximal femoral shaft in the setting of 2 months of thigh pain and no constitutional symptoms. Make one comment while you look at that. So there was a couple guesses here on the prior for non-fibroma, and that's, yes, so that's not, or at least non-ossifying fibroma can have giant cells. I completely agree. It almost can look like a dermatofibroma / fibrous histiocytoma of bone, but that tends to also have more spindly cells in a storiform pattern as opposed to those plump mononuclear cells. But yes, if you guys were guessing that as a giant cell rich tumor, yes. I,
Let me see.
15-year-old lytic femur pain. Yeah, it's kind of
I
annoying.
don't see it there, but I see it.
Yeah, you know. Do it. Yeah. Is this one? Focus this one, you can only focus the other one and then it's out of, you know, it's like. It's like Mark Lingham with that scope. I'm just kidding.
Yeah, because this one also has some disparity.
13-year-old. Proximal pain.
Yep. Oops.
So, looks like a diffuse kind of lesion in the sample,
Mm-hmm.
and it looks very homogeneous. Cells that are kind of looking similar to each other, at least on low power. There's some kind of first hyperlary kind of stroma. Giant cells on low power. On higher power, cells look very similar.
There are a lot of neutrophils in this.
You should also think about some kind of acute thing, infection. Possibly osteomyelitis, but I don't see any bone. Another thing to consider in a child is eosinophilic granuloma, Langerhans.
And have a CD1A place.
No.
They have a syncytial appearance, which kind of might go with a histiocytic lesion, and then some of them do have kind of nuclei.
Now, there seems to be like, right, these
That
sort of
one.
plumper cells and then the more squishy inflammatory
Uh-huh.
cells.
Sometimes there's eosinophils, which I'm not seeing in this field.
Yeah, eels and neutrophils can be really hard to distinguish on frozen because sometimes the granules don't pop out, so you have to look at the lobation of the nuclei. But maybe, wait, no, maybe. No, but it's got multi-lobes. That could be an eel, it's got two, but it's hard.
It's maybe one up there. Those are the things that I'm thinking. The highest one is the eosinophilic granuloma, as they like to call it here. I thought it was like a bone specific thing, or is it just our surgeons?
It's historic.
I thought it was historic just for bone, or no?
work everywhere and they have a hard time changing their phraseology. Like sometimes they still say synovial cell sarcoma instead of synovial sarcoma and like esthesioneuroblastoma instead of olfactory neuroblastoma. It's just like time. So cool. I think you guys are favoring Langerhans, yeah? That's great. So on MRI, there is a T1 hypointense, T2 hyperintense lesion in the lateral proximal diaphysis with ring enhancement, 3.4 centimeters. The underlying cortex is eroded and irregular in appearance. There is associated edema and inflammation in the surrounding musculature. MRI impression differential includes, so right, sometimes the radiographic differential is super important because it'll help you confirm whether you think you're right or not. Eosinophilic granuloma, stress fracture, chronic osteomyelitis, or Ewing sarcoma. So we can certainly say not Ewing's, right? If you miss the mononuclear cells, you might think about osteomyelitis. Certainly doesn't look like a fracture, which we just saw, right?
This is the same for Langerin. CD 217.
Beautiful.
Yep.
This is CD1A. This is 100. ACS 100. Yeah. But it's possible. 1A and the Langerin are better. What's that one? Oh, permanent. Oh, yeah, let's look at the permanent HD. So what do some of these have mutations in? BRAF. B600E. So we generally, oh, that looks necrotic, it looks all necrotic. Yeah, there. Yeah, that's lovely, right? There's a lot of plump cells. There's even some foamy histiocytes in the background. There's a lot of these nice plump cells with plump kind of grooved nuclei. Let's see, small lymph cineos, yeah. So yeah, so we did do a BRAF IHC on this, which I think was negative. I'm not sure if we're doing that, but so what else do we need to talk about with Langerhans? That it, are we good? Yeah, the boards like to test you on Burbeck granules. We don't do EM anymore, right? Because we have CD1A and Langerin, but yes, technically the tennis racket shaped granules are what they like to test you about on the boards.
Good / cutis T myelitis, that's it.
Okay. So this was called most consistent with Langerhans on Frozen. So well done, team. 0983.
6-year-old male, right hand mass. Increasing in size, painful.
You have to look, it's really awkward. You have to look at the screen and pretend the screen is your microscope.
Look like that this powers look like a structure in like the history for this case again.
66-year-old male with a right hand mass in the metacarpal. Increasing in size, painful, difficulty gripping objects. And there is a radiographically destructive expansile lesion involving the proximal and mid portion of the fourth metacarpal, eroding and destroying the cortex, 3 centimeters.
And also a lot of blurs, some that's how look like
Yeah, right.
we don't see this kind of capillary overlap on the person. A lot of necrosis which
Is this metastatic adenocarcinoma?
we've seen this kind of architecture coordination.
Mm-hmm. Good
And
point.
So this like flavoring metastasis.
Yep.
So because of this goblet cell, and do a CD92 on it.
Mm-hmm.
So on frozen, I think this is probably good enough to say metastatic carcinoma.
Yep. You need to say, and this was
Primary deferred to permanent.
absolutely, yeah, so this was called, it was called adenocarcinoma. I mean, right, I think we can agree that it's not squamous, right? It's glandular with, mucin, fine, okay. So metastatic carcinoma, adenocarcinoma. It's with a met, like,
Yeah.
That was the only guy.
yeah, well, that we know of.
Oh, we know, okay.
No,
This is CD92.
and it's positive.
Guy, CK20 is, did we do CK20?
Positive.
GI,
CK7.
so it's 7 and 20, and CDX2, a TTF negative, so something GI probably. I don't know what it ended up being. But, expect the unexpected, right?
Necrosis like we would see in a colon.
Yeah, yeah.
but their papillary architecture kind of ticked off. But we do see goblet cell.
Mm-hmm.
Maybe just kind of glandular architecture, not so much. Is that a term you could use instead of papillary, like glandular architecture?
Yeah, I mean, what's different between a villus and a papillum? I don't know, the length,
I
the
guess-
width, the
yeah, I
breadth,
don't
the
know. I was
depth.
thinking like if that makes it less, John was saying he hasn't seen papillary and colon, so I feel like we use the word glandular.
Ah,
maybe
got
more
it.
often.
So you're using the GI fellow words.
I know, right? I'm like,
Maybe that makes it more palatable to him.
yes.
How often are colonic adenocarcinomas positive for both CD7 and CD2?
The whole, like, Dr. Sekia wants to do a whole project
really?
on like why you lose seven. Or the percentage, I don't remember. They tend to lose, yeah.
This in the finger and it's above the diaphragm.
And the travel often got, oh,
It's one thing.
it's long distance.
It's long
Did they do a colonoscopy or something?
Oh, I'm sure. I don't have the exact follow-up on this patient, but we can find out what it ended up being.
With this, with all the information provided, what the primary are we? What is the primary?
Yeah, something GI. Beyond that, I'm not sure one can say. So I'm
a-
sure they,
Sorry,
no, go ahead.
I've seen a consult case for long. Well, it went somewhere else. It was right for CDX2.
Lung,
Then once it becomes mucinous or undergo like.
it loses TTF1.
Yeah, can also have rights CDX2.
Do we have,
Oh, interesting.
do we have WT1 and after ovarian?
Ovarian is a man, I
Yeah,
think.
no,
Oh.
right.
But in a woman, yeah, you'd wanna. Here, let's see if I could. Uh, that is not prostate. I don't have any good notes here. No, he looks not. Maybe he went somewhere else for his final treatment, yeah. AN2A, ERB2, TP53. Esophageal,
Sinonasal intestinal
Mhm.
type,
things like colon cancer.
there's no way that.
No, the only way to distinguish it is to make sure the patient doesn't clinically have colon cancer and
Right.
does have the occupational like wood, leather, dust exposure, yeah. You. See, not all BST Frozens are super scary. Some of them are totally manageable.
Everything, nothing.
This is the last one, guys. And gals and days.
14, lucky number. Eighty-two-year-old female. Right hip pain after a fall. Nah, never a good thing. Walking and tripped and ended up on the ground. Usually what happens when you fall. No.
Relatively cellular sort of intersecting bands to those collagen is much more cellular. Stems of some sort. Does she have a known primary? So we have areas forming little nests in some places, a little bit filing by themselves, but here, or know when was the last time she saw a doctor or had mammogram, for example, or colonoscopy.
No, is that she had breast surgery 20+ years ago with no known anything.
In terms of other possibilities, I mean, I'm worried about Americans to try to any other.
You could do an intraoperative keratin.
I could do that, yeah. Could we do that?
You could, I
Now,
mean,
right now. Or
no,
No.
I don't have it on this
We don't
case,
have it.
but if one wanted an intraoperative keratin, one could do it to confirm that they are in fact epithelial. If you were
you're so
unconvinced.
fine. Yeah.
Mhm.
I'm just thinking of others or anything like in the sarcoma family. Geosarc, like an epithelial and geosarc.
Mhm.
I mean, I guess would be a possibility if the keratins don't. But again, I don't really. These look like lands. They don't look like. That's. Like a DLBCL, trying to think of like complete territory.
Permanent.
Or
Well, let's stick with carcinoma. What? Synovial sarcoma, like biphasic. You'd have to check the background to see if you think the background looks malignant. Cause this, in synovial sarcoma biphasic, the spindle cells in the background should also look pretty cellular. And I'm not sure that these did. We can go back and look at it. This looks like breast cancer.
about stoma, we have river forming, we have tons of glandy structures. There's a plastic reaction all the way around. I think CPNI. Keratin. Let's just see. This is a Dr. Hart 1X. The keratin. Oh my goodness. Being positive. She needs. I think this is a pathologic structure. And 17.
Sure. I should have been. I don't think we need CD 117.
There, I'm very confused. Okay. Yeah,
Just look at this.
Something more than one component of the tumor.
I think that's maybe why they did the C kit because of the potential biphasic, but I didn't pan out. But I think there is some gland-like structures and there is P40, right? So I think whoever said if you said adenosquamous, I think that, you know, is potentially what we're looking at here. So no, we don't.
Did she have a ginormous mass in her house?
No, she had a ginormous mass in her lung.
In her lung?
We have TTF, but we don't have GATA because you know, when you're working up a case like this, and if you have the appropriate radiographic findings, you can tailor your immunostains to what is evident, right? And so sometimes at the same time you're working up the IHC, oh no, get another one. They're doing imaging, right? And so if there's absolutely nothing, then you can throw the book at it, right? But if there's something, you know, we can sort of say, okay, I'm not gonna do a GATA3 because now I know she has a giant lung mass and it's P40 positive. And if it's P40 positive and it's breast, then it's what, metaplastic carcinoma, and it's a whole nother ballgame, and it's gonna be ERPR negative, and right? Yes, it's always been, it's never sarcoma. Anyway, so yeah, this was called potentially adenosquamous and clinically lung.
The frozen
Yeah.
sample, like say we got a specimen, cannot tell if it's like, if we can tell it's malignant, then we cannot tell whether it's like pulmonary carcinoma. You know, whether we make the call, does the management change? Or
No, if you say malignant, it's generally fine, because they're not gonna do anything drastic.
Okay,
The only, you know, potential difference is you can't tell if it's a bone primary or a met. Because if it's a met, then, you know, curetting it and rotting it and stuff is okay, but if it's a primary, that's not okay.
Okay.
Right, so that's where I would just exert some caution, and so again, if you're uncertain, that would be a clinical discussion in terms of what they need to know at that moment in time.
For the Mets, like it doesn't matter at the time of frozen what the primary is. Maybe
Absolutely not. Yep, it was just called carcinoma, and then metastatic carcinoma was squamous differentiation, favor adenosquamous. No, the primary does not matter. People,
Thank you.
everyone, say.
that's it.